Hello, my name is John Moyer, and I want to welcome you to the NIH Office of Disease Prevention's Mind the Gap webinar series. This series explores research design, measurement, intervention, data analysis, and other methods of interest to prevention science. Our goal is to engage the prevention research community in thought-provoking discussions to promote the use of the best available methods and to support the development of better methods. Before we begin, I have some housekeeping items. You can submit questions during the webinar via the chat pod. You'll need to open the pod by hovering your cursor at the bottom of the Zoom window and then clicking on the chat icon. Please direct your questions to hosts and panelists. We will open the floor to questions that have been submitted via the Zoom chat pod at the conclusion of today's talk. The slides and video recording will be posted on our website, prevention.nih.gov/mindthegap, in approximately 2 weeks. Lastly, we would appreciate your feedback about today's webinar. Upon closing, you will be asked to complete an evaluation. We would appreciate your feedback as it will help us improve this webinar series. At this time, I'd like to introduce Dr. David M. Murray, Associate Director for Prevention and Director of the Office of Disease Prevention.
Thank you, John. Today's speaker is Dr. Leslie Lytle. Dr. Lytle is an adjunct professor of health behavior and nutrition at the University of North Carolina, Chapel Hill, and in the Division of Epidemiology and Community Health at the University of Minnesota. She previously served as professor and chair of health behavior at the University of North Carolina and Chapel Hill. Her research over the past 3 decades has centered on designing and evaluating multi-level interventions to promote community health. She's been the principal investigator on several large NIH-funded community intervention studies, and some of you may recognize the names. Catch, Teens, TAG, Choices. These were funded by either the National Heart, Lung, and Blood Institute or the National Cancer Institute. She has published more than 240 articles in the peer-reviewed literature and taught courses to master's and doctoral students on theories of health behavior change, designing community interventions, and behavioral and social aspects of health. She's the author of Designing Interventions to Promote Community Health, a multi-level stepwise approach, published recently by the American Psychological Association. It's my very great pleasure to welcome Dr. Lytle.
Well, thank you, Dr. Murray. I'm really pleased to be with you today and very pleased to be invited to talk with this. I was asked to talk about designing interventions for populations or community health, and it is a topic that, as David said, is near and dear to my heart. I recently wrote a book and it's really about designing interventions to promote community health. So why did I write this book? Well, we all know that community-based health promotion and disease prevention approaches, as compared to more medical treatment approaches, are more equitable because they reach more people. They're more cost-effective because it's always cheaper to prevent a disease than to treat one. And more sustainable because there's always a hope that the programs we develop can be maintained in existing systems in community. So why now? Well, as a society, we may be turning the corner on acknowledging and supporting the idea that we need more equitable approaches to help all communities be healthier. And with that acknowledgement, we also recognize that we need to find ways to better disseminate those evidence-based interventions that emerge. So why me? As David said, I'm a public health researcher. I've been working on designing community-based interventions for 3 decades. I've taught literally hundreds of master's students and dozens of doctoral students. And in my decades of training students and working with junior colleges, this is often what I see. For most students, not all students, but most students, learning about intervention design is really not high on their list of priorities. Students coming in usually are most excited about specific content areas. They really are interested in learning highly technical skills. They're most worried about their quantitative courses. And so learning about designing interventions is either something that they see as something they can pick up on the job, or if they're going to be doing research, they'll just hire an interventionist to do that part of the research. So it's actually been the unusual student that's been interested in learning how to design and adapt community interventions. So my goal in writing this book was to create a bit of a roadmap for those who were tasked with designing or adapting interventions, helping people think through some important questions like, what's my destination? What exactly is the health behavior and health outcome that I am trying to achieve? What are the protective and risk factors associated with that health outcome? How do I use behavioral theory? What intervention approaches will I use? How will I know if and how the intervention worked? And how do I maximize what I can learn with every iteration to make sure that my research or my program planning is progressing with each iteration? Excuse me. My book describes the design process as having 4 phases and 12 steps. And the first phase is the plan phase. It's absolutely the most important part of the whole process. It's where, with community, we identify a behaviorally based community health problem. We choose relevant behavioral determinants to positively impact that health problem. We create a conceptual model, and then we review that model with both our evaluation team and our community stakeholders. The second phase is the create phase. This is where we take those determinants that we've identified. We write intervention objectives, we identify the right intervention components to use, we design intervention strategies, we create a logic model, and then again, we share that logic model with our evaluation team and our community stakeholders to get feedback and make alterations. The fourth phase is the implement phase, where we develop process evaluation, we finalize our intervention protocol, our trainings, all our materials. If we're doing research, we pilot test our intervention in the implement phase. And then finally, our last phase is evaluate, where we evaluate the effectiveness of the intervention and then again, prepare for the next iteration or the dissemination. It's really important to note that community engagement in every phase is absolutely crucial. First, we have to be sure that the health issue is a priority for the community. We need bottom-up support, not all top-down. We need to make sure that the things that we focus on in our intervention, the determinants, reflect the determinants that are relevant to the health behavior in this particular community. It's also incredibly important that our intervention reflects community values, builds on community assets, and increases community capacity. And finally, even the evaluation that we do should not just be about our science. It should also be evaluation and results that are meaningful to the community. I don't have time to go through all 4 of those phases in detail, so I'm just going to target the plan and create phase as part of the design process today. So where do we begin this very long and complex journey? In my experience, most of the students I have some exposure to some kind of intervention planning model. And I would say they are almost all familiar with the social ecological model. So we often see social ecological models identified as the source or the theory behind a multi-level intervention. This is one that's from my friend Mary Story, that is an ecological model of childhood obesity. As you see, we've got individual factors, which is the individual embedded in the social environment, a physical environment, and the macro level environment. Mary suggests places where these are relevant, and as well as some intervention approaches to target each of those spheres. If you're in Europe, when I travel to Europe, I most often see something like this, Susan Mickey's behavior change wheel. And Susan puts capability, opportunity, and motivation at the center of her behavior change wheel. And again, suggests that there are approaches, policy and otherwise, that are possible for impacting those capabilities, opportunities, and motivation. So as someone designing in an intervention, those ecological models, these kinds of models are great heuristics to remind me of the complexity of behavior, that it is part of a much, much larger context. But if I'm going to design an intervention that's going to be evaluated, I need a different model. A social ecological model like this doesn't help me do things like prioritize factors to change. They include myriad factors, and the interventionist doesn't have any clues about what really are the main drivers to be focused on. Another limitation of an ecological model is that they don't limit consideration to factors that are mutable. Social ecological models almost always include the macro environment, and I'm sure most of us would believe that those macro environmental factors are probably the most important determinants of health. But in a time-limited intervention or in a community program that you're trying to evaluate, changing socioeconomic status or racism is not going to be possible. So focusing on factors that are mutable are important when you're developing an intervention. Those ecological models also really don't suggest a lot of mechanism for change. And importantly, they don't suggest causality. So as a behavioral scientist who's designing a community-based intervention to be evaluated, I needed a simpler model. I needed a causal model that not only tells me what I'm going to intervene on, but also helps me develop hypotheses for change. So I've been using a model that looks like this. Again, you'll see that I'm talking about the social, physical, and individual environments, just like you'd see in an ecological model. I suggest that all three of those things, those environments, impact health behavior. That health behavior is associated with some health outcome that we've all deemed is important. Those environments are interrelated. And the model also identifies the fact that there's going to be modifiers that are outside of that causal pathway, but that we're going to need to measure and think about as we try to explain the relationships between things in that model. I'm going to be talking a lot about social, physical, and individual environments. So I'm just going to spend just a minute or two making sure we're all on the same page so you know what I'm talking about. So when I think of the individual environment, I think about the space between our ears. That's knowledge about the behavior, that's our attitude about a behavior, that's how we perceive the risk of that behavior for our personal outcomes. When I think about the social environment, I think about how others influence our behavior, and that can be others that are very proximal to us, our friends, our family, but it also influences, it's also the larger culture that is part of that social environment. And the social environment includes social support, social norms, vicarious learning, and social reinforcement. When I think about the physical environment, I'm thinking about aspects of place that affect our behavioral choices. So availability, accessibility, cues, and reinforcers in the physical environment are all part of that physical environment. And I think of the physical environment as places without people, because as soon as you put people in the mix, then you've got an interaction of both the physical and the social environment. So when you're building a multi-level intervention, it is one that targets at least two of those environments. Most of my work has targeted all three. It requires building multiple interventions for multiple targets, and they're often delivered by multiple actors. The plan phase, one of the most important things we do after we identify our health behavior or health outcome of interest is to figure out what those determinants are in our local community. So at this point, we're trying to identify the protective or risk factors that are related to the health outcome of interest. And the whole intervention is built around designing how to positively impact those determinants. And to make I'm going to give you an example using TAG. So I want to just tell you what TAG was about. I'm going to talk about it when I talk about parts of the planning in the create phase. So TAG was an NHLBI funded multi-level intervention. The goal of TAG was to evaluate the effectiveness of an intervention that linked schools to communities in order to reduce the age-related decrease in moderate to vigorous physical activity in adolescent girls. And our primary outcome of TAG was minutes of physical activity measured through accelerometers. TAG was a randomized control trial. We were in 6 field centers across the country, 36 total schools. We had a coordinating center, and our analysis involved 3 cross-sectional samples of girls that were recruited for measurement activities. But of course, because this was a school-based program, all of the kids in the school were exposed to the intervention. So when we're designing a multi-level intervention, we need to start by understanding the behavioral determinants that will, again, be that whole, the whole basis of what our intervention is going to look like. And we use 3 different ways to identify behavioral determinants. 1, we examine the empirical evidence. 2, we conduct formative evaluation in our target community. And lastly, we consider behavioral theory. So when we're examining the empirical evidence, of course, we're doing a lit search, and we catalog our findings on an evidence table that might look like this. So this evidence table is not organized by articles, but rather by the determinants that are reported on in every article. So each determinant is included on a single row and organized as either being an individual level determinant, a social level determinant, or a physical level determinant. And what we're looking for is within each article, the relationship that we're seeing between determinants and the behavior of interest. So as you build this evidence table, you have multiple pages that list all the individual level determinants, the social level determinants, and the physical level determinants. So at the end of this phase for TAG, we may have come up with these 9 determinants from the empirical literature that we should consider as being part of or the basis of our intervention work. From the individual level, perceived barriers, habits, self-efficacy came up in the literature. From the social environment, the literature suggested observational learning that happens in PE class, providing and receiving social support. And at the physical environment, some articles suggested that distance between home and school, transportation, availability of PE equipment were also determinants that the literature suggested were related to levels of physical activity in adolescent girls. The second way that we identify determinants is the use of formative assessment. And I think of formative assessment as any data collection done to help inform the intervention. It can be qualitative or quantitative. Usually we use both. And it is really important, and that helps answer the question, what determinants may drive behavior in this particular community, in this particular population? And this phase is incredibly important, both when we're building a new intervention as well as when we're adapting an intervention. As an example, in TAG, we did a very thorough formative assessment. We did a survey with principals where we learned about their requirements for PE and health education. We learned about the availability of physical space for PE or in physical activity programs in their school. We interviewed PE teachers to understand their teaching methods and what they perceived as barriers to getting adolescent kids to be physically active in PE class. We did surveys with community agencies to understand what kind of programming they were offering teens in the community, and also what they saw as the benefits and barriers of increasing their programming for kids. We interviewed parents to get their perceptions about their kids' activity level. And really importantly, we did a lot of focus groups and interviews with adolescent girls to understand where they were coming from as far as what things either enhanced or inhibited their ability to be physically active. So again, from this formative assessment, we come up with some additional potential determinants. And again, they're organized by this individual, social, and physical. Perceived barriers comes up again. Self-efficacy comes up again. Lack of knowledge about what counts as an activity came up in some of our focus groups with kids. From our schools and communities, we learned that there was very little social connection between our schools and communities. They sort of knew they were there, but they never did much together. And from the physical environment, again, we heard this idea of transportation was an issue, and access to non-athletic after-school activities. So I'm going to just dive a little deeper into this just to show you how important this formative work was. So with TAG, particularly when we talked to the adolescent girls, one of the things we heard that we had not read in the literature was about self-identity. And for those of you that have teenage girls or were once a teenage girl or even a teenage boy, you know that adolescent period is really a time where kids are learning to identify who they are and self-identify. And from some of the girls, we heard that they couldn't believe that a smart girl could be an active girl. Those were sort of two mutually different ways to self-identify. They also talked about the social norms and expectations around girls being active, saying that the girls that were athletes, that was cool, they were reinforced, but the girls that weren't athletes, weren't on teams, being activity was, sort of an optional activity that they didn't get much reinforcement for. And finally, we heard from them that they saw that the girls who were in sports teams had access, had a school bus that got them to practice, whereas for the rest of the girls, they were really just going home and didn't have some activity options. The third way we identify behavioral determinants is through behavioral theory. And when I think of behavioral theory, I think of two different kinds. I think about those behavioral theories that help explain how change occurs, and theories that identify those constructs or determinants of a behavior. So when I'm thinking about how change occurs, I'm thinking about stages of change, I'm thinking about diffusion of innovation, I'm thinking about Kingdom's policy stream. We use these kinds of theories in our create phase, but in our plan phase, I'm still looking for those determinants that are related to a behavior. So I'm going to be looking for things like theory of planned behavior, the health belief model, social cognitive theory. And our intent when we're designing an intervention is not to test theory. We actually disaggregate these models and look for those determinants that might be relevant to this community. So as an example for DAG, we primarily drew from social cognitive theory. We added under individual the idea about outcome expectations. Under social, we added vicarious learning, and under physical, we added cues and reinforcement. So at this time, we now have 22 possible determinants to build our intervention around, but 22 determinants is way too many. If we tried to target all of these, we would dilute our intervention and probably would end up with nothing. So we need to make some decisions to get down to about 6 to 10 determinants. And again, because we're building a multi-level intervention, we want it to be from at least 2 environments. And some of the ways we make these reductions are, we look to see if there are determinants that show up from more than one source. And as you saw, self-efficacy, perceived barriers really showed up in all 3, from our focus groups, from our empirical literature, and also from our theory. We also look at our empirical evidence to see how strong the relationship is between the determinant and the behavior. The stronger it is, the more relevance it might have in an intervention. I look to see if other intervention studies have been successful in changing a determinant. That makes me think that there's some good success there. I might be able to identify, reach out to another investigator to see how they did this. And really importantly, It's sort of a reality check. The team needs to think about what determinants can be most realistically changed by this team at this time, at this community, with the amount of resources available. And again, because we are working in and with community, we ask the question, does targeting change in certain determinants complement the work and the mission of our community partners? And if so, adding those to our list of determinants for our intervention is a good thing. So having gone through that experience, we come up with a conceptual model, which is our third step in our phase. And you'll see that our conceptual model looks very much like the framework I showed you. We've chosen two determinants from the social environment, social norms and supports. We've chosen 3 determinants from the individual environment, self-efficacy, knowledge, again, more about what counts as activity. We've included some attitudes like outcome expectations and expectancies. And for the physical environment, we've decided to focus on resources for PE class and accessibility to after-school activities. We also know from our formative work that some of the moderators we should be thinking about include average family income at the school level, as well as at the girl level, weight category, overweight, obese versus a BMI in a healthy range. So this conceptual model ends up being not only our blueprint for our intervention, but obviously because it's a causal model, it's also the big beginning steps of an analytic plan. So the next thing we do, and we're moving into the create phase, is we write an intervention objective for every determinant. And the intervention objective is really a very simple statement that just states, how is the intervention going to change or positively affect this determinant? So I've just chosen one from each of our 3 environments. So for self-efficacy, the intervention objective is to develop behavioral skills related to girls being active in order to increase physical activity. Or the after-school program, our intervention objective is increase non-sports activities available to girls after school, both in school and community. So we take these intervention objectives and we identify intervention components, which I think of as the general approach or the general ways that we're going to realize or achieve these intervention objectives. And as I've shown you before, I can match those intervention components really onto those 3 environments. So if I'm thinking about components that will impact the individual environment, I'm thinking about things like classes, curricula, individual or group counseling, or health communication directed to an individual. If I'm looking for intervention components to target the social environment, I'm thinking about social marketing or media campaigns. I'm thinking about policy or practice changes that would impact the social experience. And if I'm looking for intervention components to target the physical environment, again, I'm looking at policies and practices that impact, in this case, the availability and the accessibility of choices or environmental cues and incentives. So with TAG, we ended up with 4 primary intervention components. TAG PE changed the way that PE teachers delivered physical education to kids. We created a health education with activity challenges, health education curriculum. Our programs for physical activity was the component where we linked the school and communities to try to increase non-sports related activity options for girls. And our TAG promotions was our component that was our social marketing component. Now, what I want to show you is that those 4 components can actually map on to both our intervention objectives and our determinants. So again, we're always going back to what is the determinant and what are we trying to change? So I want you to note that each component may impact more than one environment, and that the same determinant may be targeted through several components. So as an example, that social norm objective, which is to increase the normative expectation that girls being active is a normative positive thing. Our tag promotions was probably our primary intervention component, because that was our social marketing. We were really trying to drive home this idea that all girls can and should and would enjoy being active. But social norms are also going to be affected with tag PE, because if we change the way that PE is run and more kids are more active more of the time, girls are going to see other girls like themselves being physically active. And finally, our programs for physical activity, those programs that we're building in the community, also provides a change in social norms as girls see girls like them, the non-athletes, signing up for after-school activity. So once the components are identified, then it's time to actually build the intervention strategies. And these are the things that really make the intervention unique and highly tailored to the audience. It includes the materials, the messaging, the materials that go into creating the intervention. And it really helps to have team members with particular creative skills and expertise in impacting your community in particular. So as researchers, we may have some creative talent, but as far as knowing how to really impact or engage with adolescent girls, it really helped to have some other people on my team. This is also where we think about behavior change techniques, where we think about those other theoretical, those other behavioral theories that talk about how change occurs. So I'm going to show you what we ended up with in TAG as far as our intervention strategies. We created a health education curriculum that could be delivered by homeroom teachers, science teachers, sometimes the PE teacher. We focused on building behavioral skills, setting goals, self-monitoring, finding ways to reinforce. We also, with our TAG PE, not only did we create new lessons, create materials, give them lots of balls and cones and jump ropes, but importantly, we did a very extensive training where in our training of PE teachers, we modeled the way an active, fun PE class would look like. For our TAG promotions, we created a passport activity where girls could get their passports stamped in school and out of school activities as a way to get rewarded for being active. And again, our social marketing component really emphasized the idea that all kinds of girls could be physically active, that it was okay to be smart and active, and also that being active was a fun activity to do with friends. When we thought about, when we looked at our programs for physical activity, we looked not only at, we looked at trying to get girls into community spaces. So we worked with communities to build after-school programs, particularly engaging for adolescent girls like the STEP class. We figured out transportation after school for them. But at the same time, we wanted the community to get into the school as well. So we also designed programs where community people came into the school and offered after-school activities. So I actually need to leave the design process there, but hopefully you got an idea of how we build on those determinants all the way until we design our intervention strategies. I want to turn to a discussion about active ingredients. So, you know, when we design a multi-level intervention and we do a good job of evaluating, you know, what we're hoping is that we're going to come up with a community level intervention that's effective at improving the health of a community group. And doing so means that we should be able to adapt and disseminate that more broadly. But it's rare that an evidence-based intervention, which is what we're trying to develop, will not need some kind of adaptation for a new community or setting. It could be as simple as language, it could be differences in pictures that are used, but it might also be something more substantial, like how it's delivered or even the dose. So there's several frameworks that exist that talk about adapting evidence-based interventions, and all agree that they must be done carefully to continue to maintain the active ingredient of the intervention. So you can think of the active ingredient as the core component, the essential elements. I sort of think of it as sort of the secret sauce of an intervention. With complex multiple level interventions, it is really difficult to know what that secret sauce is. And as a field, we're not even consistent in identifying or defining what we mean by that active ingredient. So Susan Michie would say that her behavior change techniques, those specific processes designed to change a behavior, are her active ingredient. And while I really like the idea of BCTs as a lexicon for the strategies I use them all the time in my change phase. To date, there's not been really any good evidence that a BCT itself is an active ingredient. Linda Collins proposes her MOST framework, or her multi-phasic optimization strategy, as a method for identifying an active intervention component, but she doesn't define what an active component is. Rather, her methodology requires each team to identify the active component that they're interested in and then test it as a potential active ingredient. And I'm going to say a little bit more about MOST in just a minute. Another group, PCORI, patient-centered outcomes research, and many working in the implementation science field use this definition, this discriminate between core functions versus form. And those core functions are a lot like the intervention objectives. It's a statement of what is supposed to happen. They identify those as the active ingredients versus the form, which is how it's delivered, even dose. And PCORI's idea is that form is not the active ingredient, that it can be modified without too much worry about losing voltage. In my book, I prefer to use the National Cancer Institute's definition of active ingredient, which includes not just the core function, but actually the form, including content, delivery, and change strategies. So even if we could decide on what is the ingredient we want to use for active ingredient, how we want to define active ingredient, we still need to figure out how to isolate it from a complex intervention, so that when we disseminate or adopt it more broadly, that we make sure that we keep that secret sauce in our intervention. So at this time, I think there's several quantitative approaches that may be useful in identifying the active ingredient in a fixed intervention. I just want to quickly make sure we're all on the same page between fixed and adaptive interventions. So a fixed intervention is when all participants are offered the same set of intervention components in a uniform manner. And adaptive interventions, which are getting a lot of attention these days, are when aspects of an intervention can be altered at critical decision points based on some pre-specified target as a way of improving outcomes for participants. So all my work has been in fixed interventions, because when you're manipulating also the social and physical environment, I think it's much more difficult to do an adaptive intervention. So if we're doing a fixed intervention, I think there's three main ways we can work to identify that MLI. The active ingredient of a multi-level intervention. So again, I think of those as MOST, a mediation analysis, and also a comparative effective analysis. And I'm just going to give a couple examples of all three of those. So MOST, again, is Linda Collins's approach that helps identify the active ingredient before an RCT actually occurs. So MOST involves the investigator identifying an active ingredient or the active component using pre-specified criteria in either a factorial or a fractional factorial design. So as an example, an investigator may be interested in knowing whether a face-to-face component is needed in addition to his e-health intervention that he wants to eventually test in an RCT. Or it can be smaller. It can be deciding whether or not a counseling intervention can get by with 4 sessions or are 8 sessions necessary. So by separating out the effect of each of these, what Linda calls intervention components, the researcher builds an optimized intervention that can then be used as an RCT. So the active ingredients are sort of identified before the RCT is actually planned. I think one of the most basic, but I think underutilized ways to look at the active ingredient after a trial has occurred is through mediation analysis. And you've seen this picture before, but this picture sets us up beautifully for a mediation analysis to ask, what are those what determinants that we've targeted mediate the relationship between our intervention and our primary outcome, which is minutes of physical activity. We actually did a mediation analysis in TAG, and what we found is that social support, both giving and receiving, self-efficacy, and accessibility to after-school activities were significant mediators in the relationship between our intervention and our primary outcome. So for me, that gives me a clue that those things, social support, self-efficacy, accessibility, are part of the secret sauce that made TAG work. And so that if I was going to do a revision of TAG, I would make sure that I had intervention components that held those determinants. Another way we can look for that secret sauce is by doing a comparative effectiveness analysis. And that's what we did in the child and adolescent trial for cardiovascular health. So in CATCH, we followed a cohort of 3rd graders from their 3rd grade year to the 5th grade year, and as a way to look at the impact of school and family approaches to reduce CVD risk in kids. Our primary outcome was serum cholesterol. We actually collected blood on thousands of children in 3rd grade in their schools, but we also measured students' health behavior and changes at the school level. We were comparing 3 school-based components with the 3 school-based components plus a family component. And the school-based component included a health curriculum. It was Hearty Heart and Friends in 3rd grade and Go for Health 4 and 5 in 4th and 5th grade. Just like we did in TAG, we had a CATCH PE component where we retrained PE teachers to make PE class more active, more fun, and more inclusive for all the kids. We worked directly with school food service to try to positively reduce the amount of fat and saturated fat and sodium through changing menus, changing recipes, and also helping them promote healthier foods. So those were our 3 school-based components. But we also, in some schools, included also a family component. And in this family component, there were activities that were linked the family to the curriculum, but also we brought in all the families one night for a big family fun night where we had games and parties and healthy foods. So our study design for CATCH looked like this. After baseline data collection, we randomized 96 schools, 40 were control schools, 28 got those 3 family components plus, 3 school components plus the family component, and 28 schools got just the school-based component. And what we found at the end of CATCH was that we had no change in serum cholesterol. That really was not a surprise to many of us. But we did see improved eating and activity behaviors with the kids. At the school level, we saw the fat content of school lunches a drop in the schools exposed to catch. We saw increased time spent in moderate to vigorous physical activity in the PE classes. But when we compared the family plus school with school, we saw only a very, very modest benefit in dietary knowledge. This information was really important because when we went to disseminate catch, which has been disseminated to over 15,000 schools, reaching over 3 million kids, we did not include that family component. So you can imagine the greater potential that dissemination has been by having a bit of a simpler design, not needing to engage families, at the same time having positive outcomes. So my time is almost up because I want to have time for questions, but I want to leave you with just three points. One, we know that change is really challenging. Any of you who've ever tried to change any of your health behaviors know that that's a fact. But NIH and its team of scientists like yourself know how to tackle challenging problems. What is really required is a commitment to improving community and population health in an equitable way and adequate resources to do so. Secondly, as you've heard throughout my talk, community must be at the center of our community-based and population-based efforts. We must work with, through, and in community. But all communities also deserve to have interventions based on the best science possible. And that's, I think, where we come in. This means employing rigorous study designs, using validated measurement tools, appropriate analytic methods. It also means, I think, employing systematic approach to intervention design so that we can maximize the chances that our interventions will be successful. And in the meantime, really adding respect and partnership with the communities that we're working with. I do think that we are just beginning to navigate those waters for how to successfully merge our goals of engaging community and conducting rigorous science in community. So I think that will be interesting as we move forward. And finally, as a note to my analytic friends, of which I have many and to whom I am eternally grateful, some things just cannot be fixed. A weak or poorly planned intervention can't be fixed, even with the most sophisticated study design and analytic approaches. So I really believe as a field, we need to elevate the importance of the intervention. And that includes re-examining how we train our students, how studies are reviewed, the time we spent in our scientific meetings, and even journal space dedicated to explaining intervention design. With that final comment, I'll close. And again, I greatly appreciate the chance to talk with this group. And I'm really looking forward to a discussions and some questions. So thank you.
Thank you, Dr. Lytle. That was a terrific presentation. So much more I know you could have covered. And one of the questions that we had from the audience was, can you refer us to review papers? And I think you might point to your book as a good starting point for more information.
Yeah.
I've got a number of questions for you. Let's start with, you outlined an approach to intervention design. There are other approaches out there. I see Larry Green's pre-seed proceed model a lot. There are other approaches like intervention mapping. How does your approach compare to those?
Yeah, first of all, I'd say, if you have a planning approach that works for you and your team and you've been effective, stick with it. That, it's just great you're using an approach. I think one of the ways they difference is sort of that map. So it's sort of a part of it is sort of the amount of detail. So I think of the pre-seed proceed, if you were trying to get from New York to LA, pre-seed proceed shows you a map of the country and says, you're going to have to go southwest, you're going to cross the Mississippi River, you're going to have to pay attention to mountains. It's sort of a very high level approach to program planning. Intervention mapping, which I think is another great approach. It's more of your Google map, every turn, how do you get there? So for me, I needed to find a design process that was sort of between those two. With every community, it was a little tedious to follow that Google map. But again, I needed some more benchmarks than Larry was giving me. I really think that's, I think some of the other differences between my model and the others is I really believe in that importance of a conceptual causal model. And I think that's missing in a lot of models. The other thing that I try to really be clear about throughout the book is how to engage community. Because again, we're doing population-based work and having some concrete advice on how to engage with families, some techniques of our community, how to engage with community, I think is a difference in my planning framework.
Thank you.
Yeah.
As you're designing multi-level interventions, should there be a primary outcome for each of the levels that you're targeting, each of the multiple levels? Or is there one primary outcome at one level and the other outcomes are secondary?
Again, we have, because we're evaluating this, we need to size our trials. And I believe you need a primary outcome. I've usually used the individual level as my primary outcome, but I will always do secondary outcomes that are related to the level that I'm changing. For example, in CATCH, we had lots of measures of the children, including serum cholesterol, 24-hour recalls, physical activity. But it was really, we learned an awful lot too by taking measures of how school lunches changed, how PE class changed. So by adding those secondary outcomes for all levels, we can also get a better idea of how our intervention worked, what those active ingredients are. And we also learned something about changing those systems in other communities. So I think that's incredibly helpful.
Thank you. You talk about active ingredients, and there were a lot of them in some of the studies that you've described. How do you parse out the contributions of the various intervention components? They all occur variably over time. Some participants may respond to some and others to different components. How do you sort all that out?
I don't think we do, or I don't think we do it very well. And for the fixed interventions that I've done, I would say that we're not parsing them out over time. Most of the times they are delivered all at the same time. Like TAG, we had the promotions, we had the PE, we had the community things all happening at the same time. I think this idea of trying to identify the active ingredients of those kinds of interventions, I think it's really important. And I don't think we've done nearly enough work to actually identify what those are. Because again, we want to disseminate community-based interventions. And as soon as you disseminate, you're going to adapt something. So to know, what if we could get rid of a component, that would be cost savings, it'd be more efficient and more effective. I think in my mind, the best approach for doing that right now is Linda Collins's MOST approach. But again, that takes quite a bit of forethought as to what you think those active ingredients might be, and staging them that way before you do your RCT.
Thank you. You mentioned implementation science in your comments. Yeah. The focus, though, on your presentation was intervention methods. How are intervention methods and implementation methods related? Yeah.
So where's that intersection between implementation science and designing interventions? I think that's a great question. And in my view, and actually what the research says is that implementation science begins with an evidence-based intervention. So as I'm, in my book and in my work that I've done, my goal has been to increase the number of evidence-based interventions that we have, so that then they can be disseminated more broadly. And I really think implementation science is incredibly important in helping us understand how we do take an intervention that's been shown to be effective in 36 schools in four states, and disseminate that to different kinds of schools in different states. So it's incredibly important information. But you have to start with an evidence-based intervention. You don't want to implement or disseminate something that's not been proven effective. And again, I go back to those active ingredient, that intersection between when you move evidence-based intervention out into a different community, how much can that change what you're going to do in implementation science and still keep that secret sauce? I think there's a lot of really interesting work we still need to do around that.
One of our viewers asks or notes that many of the interventions related to diet and physical activity have rather small effects. What do we have to do in order to change behavior more dramatically?
So keep in mind, that the small effects are not so bad if we're working at a population level. That's that Rose's theorem. We're pretty happy in a big community-based trial. For example, if we can increase the average serving of fruits and vegetables by 0.8, it doesn't sound much for an individual's personal health. But again, when we're doing community-based or population health, we are looking at we are looking at change at a population level. So very, very small changes. For example, in TAG, we added, I think, 10 minutes of MVPA can actually make a big difference in population health. It's a different metric we're using when we are working with individual patients. So kind of a shift in thinking from Rose's theorem, which is more of a population-based approach, to a medically or clinical outcomes.
We have several comments about statistical analysis approaches, and this one is typical. Could you speak to the statistical plan a bit? Did you approach multi-level intervention using multi-level modeling or some other approach?
Well, I mean, obviously when we do these big intervention projects, I've got a world-class statisticians on my team, because I am not a statistician. And again, as you saw, I actually identify several places, even in my steps, where you actually need to meet with your evaluation team. So I don't immediately think about multi-level modeling, but I do think about creating a framework that sets up an analytic plan that very clearly says, this is my dependent variable, these are my independent variables, I'm suggesting some kinds of interaction. So for example, even that framework not only sets you up for looking at a mediation analysis, but you could also imagine it being used for some kind of structural equation modeling. So I really rely on my quantitative colleagues to help me think through the best way to analyze my data. But as an interventionist, I'm focusing on the idea that I know I need to target multiple stakeholders with different interventions, and I want to learn as much as I can from all of the intervention work that I'm doing. So that includes not only making sure I've got valid and reliable measures, but also, as I mentioned, I'm collecting the right information for my moderators to include in my model. Process evaluation that will help me understand the outcomes. So there's a lot of evaluation in there, and it really does require a team of both interventionists and folks with good evaluation experience, and our communities.
Thank you. I always appreciate encouragement for full employment for methodologists. This is going to have to be the last question, because we're coming up on the top of the hour. NIH has released several large funding opportunity announcements in the last couple of years. that have encouraged multi-level interventions to address health disparities. Can your methods be used for this kind of research? Are adaptations required?
Oh, I think this kind of my design works beautifully in trying to reduce health disparities, because again, it's got community at every level. So in fact, our catch and tag, we were always focused on making sure that we were trying to get some representation in our schools and sample of more diverse populations. I think that a design process that has community in the center of it, that is community-based, has a very good place in health disparities research. Again, I think that idea, though, that I showed at one of the last slides, that importance of including that intersection between community needs, community assets, and also our evaluation needs as scientists. I think we're gonna rub against that coming up. I think that's just something we're gonna have to work on, but is vitally important.
Thank you.
Yeah.
And I'm going to turn things back over to Dr. Moyer to wrap up for the day.
Thank you, Dr. Murray, and thank you to everyone who participated in today's webinar. On the Mind the Gap website, prevention.nih.gov/mindthegap, you'll find several resources for this talk, including the slides and a list of references. We will also be posting a recording of today's webinar on our website in a few weeks. Thank you, and have a great rest of your day.